Good afternoon, everyone. Thank you for joining the Obesity Care Advocacy Network for today's webinar, the second in our summer series entitled Community Partnerships Are Vital in Addressing Obesity. I'm Heather Hodge, and I'm going to be the moderator for today's discussion. I have the pleasure of working at YMCA of the USA and serving as the Senior Director for Community Health, and I provide support along with our entire Y network of the Y's effort to help all community members live their healthiest lives through improved lifestyle health and health outcomes. The Obesity Care Advocacy Network, affectionately known as OCAN, is a diverse group of organizations that have come together with the purpose of changing how we perceive and approach the problem of obesity in the United States. We advocate for a continuum of obesity care, including evidence-based treatment and prevention options. As I mentioned, today's webinar is the second in the OCAN summer webinar series about obesity. You can find a recording of the first webinar entitled A Closer Look at the Impact of Obesity Throughout One's Lifetime on OCAN's website. I strongly encourage you to do so. The final webinar in our summer series will be held in September and is going to focus on supporting children physically, mentally, and academically as they re-enter a traditional school year. For today's webinar session, we'll take questions from the audience later on in our program. You can submit a question for any of our panelists at any time during the conversation. If you'd like to ask a question, please open the chat box and send us a question along with your name and your affiliation. We're going to try to get to as many questions as possible. Please note that today's conversation is on the record and is being recorded, and links to the recording and additional information will be sent out following the event. I'd like to start by introducing today's esteemed panel, which represents experts with diverse perspectives on how to develop and utilize community partnerships to address obesity. First off, Michelle Cardell is an obesity and nutrition scientist and registered dietitian with a focus on the development and implementation of evidence-based healthy lifestyle strategies for adults and children, particularly those with medically underserved backgrounds. At WW, Michelle oversees the company's academic research partnerships and clinical trials. In collaboration with fellow scientists and teams across the organization, she plans and executes research studies, then implements and disseminates the findings for WW members, the scientific community, and the greater community at large. Welcome, Michelle. Next, I'd like to introduce Dr. Julie Wood, who is a family physician and serves as the Senior Vice President for Research, Science, and Health of the Public for the American Academy of Family Physicians. Dr. Wood provides oversight responsibilities for public health, scientific, and research activities of the AAFP, as well as AAFP's relationships with other organizations in the US and abroad. She oversees AAFP's efforts to involve family physicians with integration of primary care and public health, providing evidence-based guidance, population and community health, global health, rural health, maternal and child health, and ongoing efforts to strive for health equity. Welcome, Dr. Wood. And last but not least, Loria Yaden is the president and CEO of the YMCA of Greater Seattle. She's an accomplished corporate and nonprofit leader with 35 years of experience and is trained as both an engineer and a patent attorney. Loria is the first woman, as well as the first person of color to serve as the CEO in the 145-year history of the YMCA of Greater Seattle, and is the third woman and the only woman of color to lead one of the largest 20 YMCAs in the nation. She currently serves on the governor's Social Support Leadership Advisory Group for the state of Washington and the board of directors for the Laird Norton Company. Welcome, Loria. As you can see, we have a very robust panel for our conversation today, and we want to thank you all for joining us as we facilitate this conversation around community partnerships that are vital in addressing obesity. So now we're going to kick off our panel discussion. Again, if you have any questions at any time, go ahead and write them in the chat. But today's panel discussion, we're going to focus on initially with an overview on obesity treatment. So our first question is for you, Julie. Let's start with a quick refresher about obesity. Why has obesity been such a challenging disease to treat from a medical standpoint? And what tools do we have to prevent and treat obesity in the primary care setting? And Julie, you're up.
First, I'm going to unmute. I did it first. Great. So none of the rest of you get to do it. I broke the ice. Well, thank you. So I'm going to speak from the primary care perspective, and I'm really grateful to be here with the rest of our panel, representing over 133,000 of America's family doctors here. And we know that obesity and patients with obesity have many different factors playing into that. It's behavioral, environmental, genetic, and hormonal. And we're starting to really think about the chronic disease aspect of that as well. And so there are a lot of challenges with that. And our organization, the AFP, has been working on trying to develop tools and resources to help tackle that from many different angles. In a primary care setting, we have a lot of different tools. So we've tried to work on how to optimize that within the four walls of the clinic as well as outside the clinic. And before I finish my comments, I did want to share a survey that we did, and I'll come back to that. But for primary care physicians, one of the things that's really important for us is team-based care. So it's not all just the physician. So it's from the time that the patient walks in the door or even beforehand, so that we have tools to address that. We also want to be very careful to look at the equity aspects so that there's not a tiered system in that we address all the social determinants of health. We have a social determinants of health toolkit called the Everyone Project that you can look at afp.org/everyone, so that we can work on looking at all the aspects of things like transportation, food security, healthy foods, and all the policies that relate to that. And so trying to address those along with not only the physician doing so, but all the members of the team having the ability to do so and feel like they could. Our members asked us to develop a toolkit. So we did so that it could be something that is, we had about 80% of our members when we surveyed them, which is a little bit different survey than I talked about, but about 80% of our members thought it was really important, but a very small percentage of them felt like they had the ability to do something about it. And so we created the survey tool, as well as creating a neighborhood navigator for referral system. And I know we're going to talk about several different ways to do that, but we have our own neighborhood navigator, which is within our afp.org, and also in familydoctor.org, which has that is a patient education tool and has a way for patients to look at community resources. And we have a way to refer within that tool, and patients have a way to self-refer to look for resources for social determinants, as well as ways to help navigate through that system. So those are kind of some different ways that we've done that. We also have education for our members specific to obesity around weight bias, for example, to help with discussing that and start educating around that. And I think that's really important. We also have discussions around helping patients actually around motivational interviewing, helping physicians talk about that, and then helping them set their own goals around fitness, around nutrition, and things of that nature. I think another important piece of that is advocacy. So we have advocacy within our organization, looking at different types of policy advocacy, and actually helping physicians being important voices in their own communities. So I think that's an important piece as well. One of the things that I did want to tell you about that I think is a good way to set the framework for the rest of our panelists' conversations and us to interact together is we did a survey in 2020 around lifestyle medicine and changes. And I'm going to peek at my own stats so I don't get them wrong. So this survey was looking specifically at family physicians, which is what our organization does. And it looked at opportunities that we have to impact and educate our patients around lifestyle opportunities and changes. And we had about 90% were making tailored recommendations to their patients around lifestyle changes, particularly around, it could be around obesity, but around other areas where lifestyle changes were needed. And they were making those at the office visit, but recognized that a lot of this change needed to occur around outside the four walls of the office. And I think that's where all of us, had the opportunity to come together and help persons that have obesity or prevent obesity. And that included lifestyle factors within their history and physical. And that's what physicians are trained to do. That seems really natural. So that didn't surprise me at all. And 80% were still assisting during their visits, again, within the four walls of the clinic. But the numbers start going down after that, not surprisingly. Time barriers and constraints and things like that But 70% were still doing referrals within the community, but then there's 30% that weren't. So there's some opportunity. And then, but if you go down even a little less after that, is about 50% or so that were involved with advocacy. So I think we have opportunities there to engage together, both in that referral aspect, but recognizing there was a large percentage that found that extremely helpful. And then also another 50% or so that weren't yet involved with advocacy. So that's one of the things that we're trying to do, is present them with opportunities to do so and tools to do so. So I'm really looking forward to the rest of the conversation on how we can all continue to do that, how we can work together on, I think, bi-directional types of information flow and advocacy together. So I'm really excited about to hear the rest of the conversation and answer some more questions. So thank you so much for the opportunity.
Great, thank you. Thank you for sharing some of your statistics too. I think that helps set the stage for where we may start to have some opportunities. So thank you. Michelle, can you speak a little bit to what your research has highlighted about obesity, and why do you view community interventions as a crucial aspect to treatment?
Yeah, absolutely. So first off, thank you all so much for inviting me to be here today. It's a real treat to be here with you all. So I recently joined WW, so this is still a new venture for me. I joined in March, and before that, I was kind of your traditional academic faculty member at University of Florida College of Medicine, where I continue to be on the faculty. And my research focused on two areas. One was the influence of psychosocial factors, so things like food insecurity, experiences with discrimination, low perceived social status, as well as stress and its influence on eating behavior. And the second area of my research was focused on the development and implementation of community-engaged, effective behavioral weight management and healthy lifestyle interventions, with an emphasis on reaching medically underserved populations. And so my research focused on how the psychosocial influences reinforce just how complex the development of obesity really is. So just as an example, in two of our studies, we experimentally manipulated social status in a laboratory setting and evaluated the effect on eating behavior. And what we observed was that randomizing individuals to a low socioeconomic status position, even for 40 minutes in a laboratory setting, that was enough to have those individuals eat approximately 130 more calories, more saturated fat, more sodium, and a greater percent of their daily energy needs than those when those same exact individuals were randomized to a high social status condition. And what was really interesting about this work is that other labs across the world started, after we published our study, started doing experimental manipulations of social status using different paradigms. And they observed similar results in an acute setting. So our experimental manipulation exposed people to a low social status condition for a short 40 minutes. But what I took away from that is I think about how do our bodies respond to chronic experiences with low social status, which can be due to things like socioeconomic status, race, ethnicity, gender or sexual identity, or weight stigma, or the intersection of some of those factors. And when I think about it in that way, I think it's reasonable to expect that experiences with inequity can lead to a very insecure environment, which seems to result in our body, being driven to consume excess calories, particularly among women. And interestingly, this parallels what we see in the animal literature too. So this research was really important for me in helping to kind of take a new route when developing healthy lifestyle interventions. And the last intervention I was working on was for adolescents with obesity. And we took a community engaged approach in the intervention development, and it was highly effective for engaging and retaining adolescents in the study because we took a really multi-pronged approach. First, we spent a whole year just doing formative work. So we did a really deep dive with adolescents, and they shared with us what were their barriers to a healthy lifestyle, what were their facilitators to a healthy lifestyle, and what was it that they wanted in a behavioral weight management program. And one of the key indicators that stuck out to us was they didn't want a behavioral weight management program. What they wanted was a healthy lifestyle intervention. You know, these teams are so insightful and so much more, you know, experienced and thoughtful than at least I was as a teenager. And they're like, no, we don't want to just focus on weight management. We want to look at health as a holistic picture. We want something that focuses on mental health, physical health, social health, emotional health. And so that is what we provided for them. So with that important feedback that we learned in these focus groups, we developed a drafted curriculum, and then we hired adolescent citizen scientists with obesity. So this was a paid position. We hired a group of adolescent citizen scientists who are experts in their own lived experience to provide insights and feedback on the curriculum that we had. You know, we also hired an adolescent citizen scientist to develop our recruitment materials, and the teens voted on the name of the study. You know, so really, you know, we continue to engage these teens, these adolescent citizen scientists through the curriculum finalization, and got iterative feedback from our participants throughout the course of our feasibility trial. So ultimately, you know, this was a program that was very much developed for teens by teens, you know, and we continue to do qualitative interviews following this intervention. And just from a clinical perspective, it seemed to be such a better experience for the teens than this kind of top-down approach of like, you know, as an expert, like, this is what we think we should be developing, without taking that community engaged approach. And I just don't think that that is effective. You know, the data and implementation science is really showing that this is where the field of obesity needs to be moving. So ultimately, you know, this work, along with my research, where I saw how inequity played a significant role in obesity development, really taught me the importance of community engagement in all aspects of intervention development, which is why, you know, I continue to teach a course titled Community Engaged Research at the University of Florida College of Medicine. And it's something that I'm very passionate about.
Thank you, Michelle. There are some nuggets in what you just shared around the importance of engagement and community intervention, which is a perfect segue into our conversation around community partnership. So my next question is for you, Loria. Would you share a little bit about the community interventions that your Y, the YMCA of Greater Seattle, has developed and or that you've adopted really to address obesity for youth and families? And then what are some of the best practices that you've discovered through this process? And if you've had any major challenges that you've faced in providing care for individuals with obesity, if you could share a little bit about that as well too.
Yes, Heather, first of all, thank you. And thank you to OCAN for the invitation to be here. I'm delighted to be here to engage in this conversation. I was listening to my fellow co-panelists, and I see your heart and your hard work in this area, and I so appreciate it. Julie, you talked about the toolkit and community. Well, the Y is your partner with that toolkit. And we are so excited to be in this area because we know what this does for community. So first, let me share a little bit about the YMCA of Greater Seattle and our health programs, our interventions to help community achieve what we talk about in the way of whole person health related to weight management. And, you know, when we talk about this area, we tend to steer away from the word obesity at our Y because it tends to be stigmatizing and it turns off many people. And our weight management programs, there are two of them that I want to share with you today. One is called Lose to Win, and the other is called ACT, Actively Changing Together. ACT and Lose to Win, they're both 12-week programs focused on learning and weight management. Lose to Win is an adult program, and ACT focuses on helping youth, not just the young person, but also their parents, their caretaker, and other family members. Helps them to learn to make healthy behavior changes in the home, and they do it together. That's the sustaining piece of it, is to do it together. Most people get connected with these programs through a referral from their provider, their healthcare provider, and also through being involved with the Y as a member of the Y. And by the way, anybody can be a member of the Y with our Affordable for All membership model. So just a few more words about our ACT program in particular. I saw a comment in the chat about something for younger people. This program is for younger people. It's developed in partnership with Seattle Children's Hospital to help kids between the ages of 8 and 14 years old, to help them help to adopt healthy nutrition habits, to increase their physical activity, and to develop a healthy lifestyle which lasts for a lifetime. It's the sustainability piece that's so critical. Kids with a BMI greater than 85 percentile are referred by their provider to the Y for this program. Now, both of these programs, we acknowledge that a focus on weight alone and the label of obesity are incredibly stigmatizing and have caused great anxiety and challenges for people of all ages. So the clinical sector tends to see weight as the main issue that they want to address, and it's part of it, but it's not the whole story. At the Y, we know that there are so many other root causes and underlying factors. And Michelle, I think your research is bearing this out, right? The work that you're doing, it shows this. There's so many other root causes and underlying factors in a person's daily life that needs to be addressed in order for healthy living through weight management to be possible. So for this reason, all of our programs are built to lead with empathy and listening, to really understand, to meet our participants where they are with encouragement and support. We put the reins in their hands. We give them the tools that they need to own their own health, for a lifetime. So none of our approaches is prescriptive. We won't tell our participants exactly what to eat, not to eat. There's no right or wrong way to be physically active. And we provide the knowledge, the tools, the ideas, the support that they need to build healthy habits and routines that will make sense, taking into account the realities of their lives and their lifestyles, and to align with their unique values over the long haul. We're about long person health. I started with that, and I'm emphasizing it again because that's the key from our perspective. We know that 80% of the participants in our Lose to Win program, yes, they lose weight. But even more importantly, we know that 93% become more mindful eaters. 78% increase their physical activity. 58% improve their stress management. And 68% decrease their negative thoughts about themselves. All of that is important to getting people to where they need to be for a healthier future. So those are all very important numbers. These are numbers that are just so much more important than the numbers on the scale. So in the ACT program, we're looking for program impact on both the parents and the youths themselves. We've seen statistically significant changes in parenting, how parents parent, by limiting TV, by limiting access to high sugar, as well as high fat foods in the home, and also in the children's consumption of vegetables. That's going up. Participation in youth sports is going up, screen time going down, and many have self-reported emotional quality of life. So we're seeing some great things from these programs. I'll stop there. Turn it back to you, Heather.
Great. Thank you, Gloria. Thank you for sharing, right? I think one of the things that's really important to point out in the conversation we've had so far is that, as Julie said, there's 20% of health happens in the clinical environment, in those four walls. 80% of it happens outside of those walls. And what we've just heard and what Michelle your research is bearing out, as Gloria pointed out, and what Lori has shared is that the community, whether it's your local YMCA or other community organizations, we have a role to play in helping to support obesity and weight management in community, as well as connecting around all those other determinants that can inform someone's opportunity to have a healthy lifestyle or a healthy future. So I thank you all so much for sharing so far. And Julie, this next question is going to keep us on this community partnership role on this path. What do community partnerships look like from a family physician point of view? And are there any best practices or challenges that you've experienced?
I think it does continue on that theme, so I appreciate the question. It's for me and for my colleagues, I think it's basically kind of like you said, it's that extension of the practice. For us, it's very helpful because it particularly helps our patients because we aren't there. We don't have that ability to reinforce and help as much as we'd like. I always felt like I wanted to have ongoing conversations. Our team did. We very much are into that team-based care model, but I often only have 15 minutes with a patient. And many of my patients that have obesity or weight management issues have many other issues to discuss. So I would see a patient that perhaps has obesity, but they also have diabetes and high blood pressure and high cholesterol, and is coming in to see me that day, and they also have depression, and they're having many other issues going on in their life. And so I want to address those with them. I want to address talking about some changes that they can make. And those aren't quick conversations, but to have meaningful conversations about how to help with the medical issues, the actual medical issues. And I want to have a good conversation and talk about, we're going to change these medications today and really talk about what that can mean. But to sit down and talk about what's going on in their lives that's impacting them and their nutrition and their fitness, and are they in an area where they can walk safely? And that takes a lot of time to do it well and in a way that that changes how they can do things. And so I am so grateful to have the programs like what you're talking about and the research that supports that, because I would love to have, the ability to have ongoing and follow-up, type of conversations. But those programs that you're talking about, Loria, where you can do that and have trained people and compassionate people to do it, it's that extension. And I think the best practice of bi-directional feedback. So when we have reporting back, so I hear what my patient is doing, and when they come back and they're excited, they are getting feedback and they're making progress, and we can talk together and get reports that they're glad for me to get back. So I think that's what's really exciting and helpful. And they have goals, and we're hearing about it and we're working together, and that's where it's extremely helpful. So I think that's probably the best thing. Challenges, I think, is still, if we can work out where there are referrals that I know where it's a place my patient can go that they can get to. So it comes back to those social determinants. So where is the YMCA or other referral source that is on my patient's bus route, or where he can get a ride to? Is there access they can go to? Is there childcare available to them so they can go and get these resources? That's one of the things that's really important. And many Ys do have that available, which is wonderful. But those are some things that I would think about as, is it available when they can miss their work and get there? Those kind of things come up. So those are things off the top of my head. But it's a wonderful piece that I think of is, I mentioned team-based care is really important, how I think of, and whole person care, which I just made my heart sing when you said that, Loria, because that's one of the reasons I went into family medicine. So when you said that too, that made me really happy. And so I think we're all kind of on the same page doing it, helping people from different angles, but from important ones. So I think I'll leave it there.
Great, thank you. And actually, I think you set up our next question for Michelle very well too. And you mentioned some of the challenges. So Michelle, in our first webinar in this series, we focused we talked about many of the barriers that patients with obesity generally encounter when they're trying to access treatment. So from your perspective, how do barriers come into play? And how does that manifest itself when we're talking about individuals with obesity trying to access treatment?
Absolutely. For me, the first barrier that comes to mind is experiences with weight stigma and discrimination. in talking with patients, and the data is clear. It comes up over and over and over again. And at WW, we recently sponsored and published some studies in collaboration with Dr. Rebecca Pohl, which found that over 50% of adults surveyed across 6 different countries reported experiencing weight stigma, usually starting in childhood. And those who internalize those experiences with weight bias and discrimination and feel that self-blame for their weight are more likely to avoid healthcare, obtain less frequent checkups, and feel like they receive less respect from their healthcare providers. So this specific study that I'm talking about compared experiences of adults in Australia, in Canada, France, Germany, the UK, and the US, and is one of the first really multinational studies to examine the link between weight stigma and negative health encounters. And they also observed that people who had experienced weight stigma reported a more frequent judgment, from doctors due to their weight, and felt that their doctors weren't listening to them carefully or respecting what they had to say. So, weight stigma and discrimination is, in my view, the primary barrier that a lot of us, are focusing on, as well as access to care. But as a global leader in weight loss and wellness, we believe at WW that it's essential to find solutions to combat weight stigma and empower those affected by stigmatization, which is why we partnered with the Rudd Center for Food Policy and Obesity and the PI, Dr. Rebecca Pohl, to work on the largest weight stigma study to date. And we will continue to work towards actively fighting weight stigma because it is such a significant barrier.
Thank you, Michelle, for sharing that. And then this question is also tied back to the previous webinar that we had, and it's for you, Julie. On the previous webinar, we talked about the impact of COVID-19 and how it's highlighted the urgency for addressing obesity in the United States, as patients with obesity are at greater risk for developing severe COVID-19 illness. And how has the pandemic, in your mind, shifted the community partnership landscape? Would just love to hear you share a little bit about that.
I think there's a number of factors there. I mean, we certainly had concern about that throughout the pandemic and still do. I have concern about vulnerable populations, communities of color, and I have concern about people having more access to care. I think people were less likely to come in for preventive care, for chronic disease management, and there's just an increased burden of illness overall throughout the pandemic. And I think we're just going to see that continue to play out now and as we get through the pandemic. I know some people are starting to say post-pandemic, and I think we're still well within the pandemic. So we have a lot to still work out there. There's less in-person access to care still, although that's probably better. So I think we have a lot to continue to worry about. And I also worry about increased anxiety and depression. And we just talked a little bit about that, the stigma, and we have anecdotally, I don't know that we have data yet, maybe we do, and Michelle could tell us, we have people that have gained further weight, even people of normal weight during the pandemic because they've been in more. And so I think that is another thing that we have to worry about. So those are some of the issues that we have.
Thank you. As many of our panelists have shared so far, the community intervention approach in treating obesity goes hand in hand with a health equity framework. So we want to dive a little bit deeper in this topic. And Loria, I'm going to come to you to hear in what ways does health equity come into play when thinking about community partnerships from your perspective?
Sure. So first, I want to go back to something, if I may, that was raised about, having access to childcare when you're, going in for a program. How can you be in a place where you can free yourself from your situation to focus on yourself? And, therein lies some socioeconomic inequities for people at times. And I'm proud to share Julie, that the Y does have a kid zone. So you come in for one of our programs, yes, the Y can provide some care for your kids. And that's intentional because we know that that's an important part of people being able to focus on themselves and to take care of their health. So at the Y, we believe that everyone deserves to be healthy and to be their best selves, realize their full potential in spirit, mind, and body, independent of their race, their national origin, their gender, and their zip code. And for many, there are inequities that present barriers to these opportunities. And as a result, not everyone has access to the tools needed in day-to-day life, like childcare, to be able to prevent or to manage their weight. So, living what is considered to be a healthy lifestyle for many is a privilege. And it assumes that you have access to the financial and the time resources that you need to be able to purchase healthy food, to be able to cook healthy meals, and even join a gym. So here's an example of how this came up for us in the course of our ACT program. As we built connections with one of the families, we learned that there's a single mom of 3. She worked 2 jobs. She cared for her elderly mom who was in poor health, and she was experiencing periods of food insecurity. So this family's socioeconomic situation contributed to the barriers that they experience in implementing healthy habits. And this is a vicious cycle, right? It's a vicious cycle of that gets into avoiding healthcare because of the financial challenges, which are compounded by the lack of access to healthy food. And all of this made it nearly impossible for this family to build healthy habits. So, we find that many of our participants who come into our programs find themselves in similar situations. And it's often rooted in some systemic barriers that have been in place for a long, long time for multiple reasons. And the Y steps in and tries to address this reality in multiple ways. First, we make sure that our programs are accessible. So in terms of costs, physical access, and language, we try to bring language skills into the picture. If there's a need for transportation, we try to help with that. And also in terms of costs, we supplement program fees or even cover it so that if we don't want cost to be a barrier, and to the best of our ability, we supplement whatever the situation is for those participants. Now, we can only do that to the extent of our own fundraising, because programs like Lose to Win and ACT, they're not covered by government programs. And so unlike diabetes prevention, which is a program that we sponsor that is covered by Medicare, Lose to Win and ACT are not. And so that needs to change so that places like the Y Community Partners can be that toolkit for everyone without financial resources being a barrier. We're also bringing our programs outside of our walls into community. That's a place of greater safety, security. People feel more comfortable in their own environments. And so we deliver our programs in cultural centers. For those who can't get to a branch, we've also offered these programs online during the pandemic. We will come into faith organizations, schools, public housing. You have to take it to where people are in need, and that's what we do. And I mentioned the virtual programming piece. So first, or second, we also tailor our programs to the communities we're working with. We speak about food choices that make sense for the norms in their community, and we acknowledge the actual availability of things like fresh produce in their neighborhood. Sometimes it's not available. So how do you work with what they have access to? That's so important. We also offer physical activity options like women's only workouts and women's only swim night. that are necessary to make, for example, many Muslim women we work with feel comfortable being physically active in a public space.
Great. Thank you, Loria, for sharing some of the ways in which your Y has worked on addressing and breaking down some of the barriers. And I think that takes us to Julie. What are some of the impactful steps we can all take? We know there's a lot of nuance, it's a complex issue, but what are some of the impactful steps we can take now in order to overcome some of the barriers to obesity treatment and care?
I think from the very quick, short-hanging, low-hanging fruit type things, it's working on how do we work together to help develop some infrastructure in the community. So how do we come together and communicate what we're doing right now? All these programs sound really good, but we can lift each other up and say, make those strong, supportive statements. So if I know that Loria's program exists, first of all, I need to be doing my part as a family physician to find out what exists in the community. And Loria and her team can be letting me know and my teams know that these programs exist in the community. And then we let our fellow patients and clients know about them. So I think one of the things we've learned, and I think family physicians are good in our training about certain things, I would say about, for example, immunizations. That's a hot topic right now in many ways. But we're trained really well in saying there's evidence that a strong statement is important. Like, I recommend that you get this shot. It's important for your health. And that we know that goes a long way. But if we can start doing things a little bit more along that line, I recommend this program. It's really important for your health. I believe in it, those kinds of things. So start going in that direction a little bit more than, hey, here's this thing down at the Y. It's pretty good. So we start doing those kinds of things on our side. And the community program is the same thing. I recommend you follow back up with your family physician. We're all part of the same team. We all work together. And that's one thing I didn't really say, I think, in my last comment, that the extension, it's more than the extension of the clinic walls. We really are on the same team. It's a group without walls. We're all working together. So I think starting to make those more profound comments and really build each other up. And in doing so, we build up the person who's working hard, or the family that's working hard to get healthier.
Thank you. I think as we think about the solutions, right, trying to find some solutions to help, a couple of things that come to mind that I heard, Loria talk about is so coverage. And as you said, Julie, like trying to dig through all the things available in your community from the physician side, and the community trying to inform physicians about the multitude of services that might be available, or how do we take the research that Michelle's doing and get it into practice. There's also a policy solution that can help us address some of these concerns, and that's through the Treat and Reduce Obesity Act, or TROA. I have a hard time saying that word, which is recently reintroduced in both the House and the Senate by a bipartisan group of legislators. And this bill aims to effectively treat and reduce obesity in older Americans by enhancing Medicare beneficiaries' access to healthcare providers that are best suited to provide intensive behavioral therapy, and by directing Medicare Part B to cover Food and Drug Administration approved obesity drugs. So we often know that where Medicare goes, private insurance tends to follow. So I think we also need to be mindful of the policy opportunities before us. So one of our asks for everyone today is to encourage your member of Congress to sign on to this bipartisan effort to support TROA, now that it has been reintroduced in both the House and the Senate. And I think we are maybe able to put in the chat the bill numbers, but you can go to the Obesity Care Advocacy Network.com maybe it's / I have those backwards, sorry, advocacy. So we'll leave it to our OCAN counterparts to make sure that everyone has the right access to be able to go and encourage our members of Congress to support that important piece of policy legislation. This has been a very robust conversation to date, but I can see that there's been some traffic in our chat. So I think our audience has some questions for all of you as well. So thank you to the panelists for sharing all your thoughtful insights. And audience, if you still have a question, it's not too late. So please feel free to open your chat box and send those questions along as well, include your name and your affiliation. So while we're waiting for some of that, we did have a couple questions submitted even in the registration process. So my first question is going to go to Julie. This came in. What barriers do you see in your practice in community-based programs that hinder the delivery of obesity care to people with intellectual or physical disabilities? And what solutions have you found to address those? And Julie, you're on mute.
Can you say the first part of the question again? Is it a barrier question?
Sure.
Okay.
Yeah, what barriers do you see in your practice and community-based programs that hinder the delivery of obesity care to people with intellectual or physical disabilities?
I'd say, now keep in mind, I haven't been in practice for a few years. I've been in more of a policy environment, but I practiced for about 20 years before that, and I still work with practicing docs. So I'm answering kind of from those two angles. So prior practice and then helping current doctors in practice. In my prior practice, that was in inner city Kansas City and then in rural Missouri. So those are the angles that I'm working in from my prior practice experience. Probably coverage. So different, I worked with mostly Medicaid and Medicare and some commercial insurance. So that was really variable. Transportation were some of the biggest ones. Mental health coverage was really hard. And I know that wasn't for obesity specifically, but coverage for treatment was really hard. And I also had, in my Medicaid population, I had a lot of difficulty with dietary and nutrition and dietitian coverage if I wanted to get coverage for that. So that was one that was challenging. And then transportation to those services. So if I wanted to try to do anything outside of my office, getting them to those services was a challenge.
Okay, thank you. Thank you for sharing that. And again, we do have several questions coming in. Our next one's for Loria. Are there any grant programs or funding opportunities that you're aware of to address obesity and encourage healthier lifestyles for our communities?
Yeah, so, in general, I'm not familiar with grant funding available to address obesity or weight management per se. However, we pursue grant opportunities that work more upstream, right? Through grants from local foundations and national funders to address chronic health conditions that relate to obesity, such as hypertension and diabetes. And we found that if we can demonstrate certain things, then those funders are pleased to walk alongside of us. And then there are other funding that address healthy lifestyle programs that flow from the CDC. So I'd look there for more of those preventative health funding and block grants that go to state and local public health departments. So those are a few areas that I would suggest from a grants perspective.
Yeah, thank you, Loria. I think your example of, when you can build some strong partnerships with your funders, they're sometimes happy to work alongside you, right, as you're learning and building potentially the evidence. And I think the public health departments are a great example also of on the public side where there are some opportunities. Our next question is for you, Michelle. What are your recommendations for mitigating weight bias in healthcare providers?
Yeah, it's a great question. So unfortunately, the studies do show that healthcare providers are not exempt from weight bias. So there are some really great interventions and work being done, particularly by people like Dr. Scott Bush at Cleveland Clinic, Dr. Emily Durander at Obthera has done some really great work doing some preliminary studies in educating healthcare providers, specifically focused on physicians during medical school. So, during those 4 years, on average, physicians only get access to about 24 hours of nutrition-based education or education around obesity. And here at University of Florida College of Medicine, I've been teaching in that nutrition intensive that those students get for the last 6 years. And when I go and talk to them, I tend to focus my presentation on social determinants of obesity and these psychosocial factors and how they influence eating behavior and this physiological drive to consume excess calories. And we talk about socioeconomic status and discrimination and, being part of a vulnerable community and the intersection between those things. And oftentimes the medical students will come up to me afterwards and be like, no one's ever talked about socioeconomic status before in our medical school training. No one has talked about the experiences of discrimination and how that it can affect someone's health. And so I think that we have a real opportunity there in that early education and training to have an effect, because when the studies show that Dr. Bush and Durander have done, that when exposed to training against weight stigma, that it really does change physician attitudes and practices. And I think the same should be true across all healthcare providers, nurses and nurse practitioners and psychologists and registered dietitians and exercise physiologists and behavioralists and all of us who are privileged enough to get to work in the area of weight management.
Thanks. Thank you, Michelle. It actually, my next question, I'm going to keep with you for a second because you opened the door to the answer. I just want to make sure if it's there, we can capture it. And then Julia, I'm going to actually ask you the similar question. But this question from our audience is, what, if anything, has changed about the kind of training medical students receive for obesity treatment? So you sort of touched on it, Michelle. I want to give you one more pass at that piece of this, and then Julia asked you the same question. What, has anything changed, or what, if anything, has changed in the kind of training medical students receive around obesity treatment?
Absolutely. So I will say, anecdotally, I don't have data to support this, but anecdotally, I do see kind of a culture shift where medical schools are recognizing the importance of training around not just obesity-related diseases like diabetes, hypertension, but actually managing the weight piece in and of itself. I'm also seeing a lot of development in new and innovative programs like culinary medicine, and a lot of physicians getting more interested in learning about nutrition. And so I'm hopeful, ultimately I'm very hopeful. I think the advocates like Obesity Action Coalition, for example, has done an incredible job of advocating on behalf of increasing access to weight stigma education in medical settings. So I'm hopeful that we're going to see a downward trend in this.
I can't comment officially on medical school curricula, but I do see some of the same things that you're describing, Michelle, particularly even more so in the residency training areas and more involvement with particularly active involvement with like group visits, kind of the walk with the doc type of, lifestyle medicine. Our lifestyle member interest group is really thriving. And so it's much more involved with getting involved with the patients and hands-on type of learning and involvement. But I can't really comment on curricula.
Okay, thank you both. Luria, this is a question for you from one of our audience participants. As a health coach and exercise professional, what is your number one tip that this individual can use to build relationships with the medical community? How can this individual build a bridge between the work they do in community and connecting with physicians in their area?
Yeah, so thanks for whomever asked that question. It gives me a great opportunity to follow up something that Julie said earlier, which is, putting together information that providers can hand out to their patients. Even materials that we co-create and co-brand together. We need to have the conversations to how we can best serve as the village for those who need our support. So I think it's walking in, planning the meeting and having the conversation, with our hearts on our sleeves and say, we really care about community. How do we do this together? How can we augment what you're doing, inside of that 15-minute visit? And then we take it from there and then give you feedback of what we're seeing in the trenches so that healthcare providers can continue to evolve, how they're supporting and treating their clients. So that's one thing that I would suggest. I think it really means all of us getting more deeply in the trenches with those who need the support and listening intensely and coming together to hold forums to get more information out to community. I mean, there's a local doctor here who we're beginning to work with, who's really turning our thinking upside down, even as to how we communicate and think with those come in for our support to get on this health journey, thinking about all aspects of it, beyond the eating, beyond even some of the social determinants. I mean, getting into, some of the hormones. I think Michelle mentioned this a little bit, and looking more deeply at really what's going on with that individual. So I think it really takes all of us coming together to share what we know and to come up with and try some things. We can come up with a solution, but make it iterative, always listening to those who are receiving the support. That would be my suggestion.
Great, thank you for sharing that. And I know your Y, as well as some others in Washington and Michigan and Massachusetts, are participating in a project with an organization called Health Begins, focused on community health detailing. So it's taking the detailing model that's often done in the pharmaceutical world and utilizing community organizations to detail healthcare providers about community level or interventions. So I think there's multiple ways in which there's some learning from that can also help address some of that. How you build your like you said, going in with an open agenda, but an opportunity to co-create solutions that work best within your community and context. I want to recognize that we received a lot of questions from the audience about mental health and obesity, and we will be covering some of that in our next webinar in September. So, we're getting close to time. So I am going to help us wrap up here. Again, thank you so much to this amazing panel of experts who have lent us their time and their brain today. We could feel their passion. So thank you so much for sharing your insights. Thank you to all of you who joined us on the phone today, who took time to write your questions in the chat. Continue the conversation with us by following OCAN on Twitter at Obesity Advocacy, and by searching for the Obesity Care Advocacy Network on LinkedIn. And again, we have one more in our summer series that's going to take place in September. And this one is supporting children physically, mentally, and academically as they re-enter a traditional school year. So just wanted to have a chance to put a plug in for that webinar as well. Again, thank you to Julie, Michelle, and Loria for spending time with us today and sharing your expertise. And thank you to OCAN for giving us this opportunity to share more about the value of community partnerships and how they can help address obesity treatment in our communities. So with that, thank you all. Enjoy the rest of your afternoons and